Welcome to the deep dive. We're jumping straight into a stack of detailed revision notes you've shared with us, focusing laser-like on one specific medical condition, syphilis.
That's right. These notes are pretty comprehensive, laying out everything from the basics of what syphilis is, how it spreads, right through to its varied presentations, diagnosis, and, management.
And our goal here is really to cut through the density, pull out the absolute most important high-yield information from these notes strictly about syphilis, and make it stick for you. Think of it as turning pages of facts into, well, truly memorable, actionable knowledge, perfect if you're revising or just need to quickly get a solid grasp on this condition.
Precisely. Understanding conditions like this thoroughly is, well, it's fundamental, and these notes provide an excellent framework. We'll walk through all the key areas they cover.
Okay, let's unpack this material then, starting with the absolute core. What exactly is syphilis, according to these notes?
So the notes define syphilis simply as a sexually transmitted infection, an STI. The crucial bit here, though, is that it's caused by a very specific bacterium.
A bacterium. Okay, not a virus or fungus.
Exactly. It's caused by Treponema pallidum. Remembering it's bacterial is really key because, well, it dictates how we approach treatment.
Got it. Treponema pallidum.
Yeah.
And how does someone actually contract this bacterium? What do the notes say?
The primary routes highlighted are through sexual contact that includes vaginal, anal, and oral sex.
Oh, okay.
But importantly, the notes also mention mother-to-child transmission during pregnancy, which leads to congenital syphilis.
Yeah.
And less commonly nowadays, transmission through blood transfusion. So while sexual contact is the main player, it's not the only way it spreads.
That makes sense. And this isn't just a localized issue right at the start, is it? The notes seem to indicate it progresses through stages and can affect various organs if it's not treated.
That's a critical point. From the moment of entry, Treponema pallidum has the potential to become a systemic infection spreading throughout the body.
Systemic, okay.
Yeah, this progressive multi-organ potential is what makes understanding the different stages so vital later on.
Right. Okay, speaking of how it's acquired, the notes list specific situations that increase the risk. What are the key risk factors identified in the material?
Yeah, the main risk factors detailed are unprotected sexual intercourse, having multiple sexual partners, engaging in what the notes term high-risk sexual behaviors, having a history of other STIs, which kind of indicates higher exposure risk anyway.
Sure.
And specifically, being a man who has sex with men is highlighted. These factors fundamentally increase the probability of encountering and transmitting the bacteria during sex.
It logically follows, doesn't it?
Yeah.
Anything increasing exposure probability is going to be high risk. And we'll see how these factors play into the epidemiology later, I imagine.
Exactly. It just boils down to opportunity for the bacteria to spread.
Okay, here's where it gets really interesting for me. How does this tiny Treponema pallidum actually do its damage once it's in the body? What's the pathophysiology described in these notes?
Well, the notes explain that the bacterium typically enters through mucous membranes or through tiny breaks in the skin.
Yeah.
Once inside, it doesn't just stay put. It rapidly invades the bloodstream and the lymphatics.
Wow, quickly.
Yeah, establishing a systemic infection early on. This ability to travel throughout the body via the circulatory and lymphatic systems is absolutely fundamental to how the disease unfolds.
Ah, so it's circulating from pretty near the beginning. That explains why it can have effects so far from the initial entry point and across different organs then.
Precisely. And it's this systemic spread that drives the progression through those distinct clinical stages we mentioned. Primary, secondary, latent, and tertiary. Each presents differently because the bacteria are affecting different parts of the body over time.
Gotcha. A simple way the notes suggest remembering the spread. Think of pallidum traveling per the plumbing, blood vessels, and lymph channels. Makes sense.
Yeah, it's a neat way to picture it.
Okay, let's zoom out a bit then and look at the bigger picture. The notes paint who is affected and where, particularly focusing on the UK data provided here.
Right. The key trend highlighted is a concerning rise in syphilis incidence in the UK.
A rise, okay.
Yes, and the notes state this increase is particularly pronounced among men who have sex with men, especially in urban areas. It's noted as a notifiable disease, too, meaning cases are tracked by public health bodies like the NHS.
And the numbers mentioned are quite striking, actually. Globally, an estimated 10.6 million new cases occur each year.
That's huge.
And within England, diagnoses of infectious syphilis have actually tripled over the past decade. Tripled.
That tripling is a really significant public health indicator. The notes explicitly confirm that gay and bisexual men in urban centers constitute the majority of new diagnoses in the UK.
Right.
And the material also specifically points out that, according to this source anyway, Black individuals have the highest diagnosis rates in England.
Wow, that's a clear pattern emerging from the data provided here. Understanding these demographic and geographic trends seems vital for directing public health resources, doesn't it?
Absolutely.
It shows where prevention efforts, targeted testing, and awareness campaigns are most urgently needed.
Exactly. Data like this directly informs effective public health strategy. You need to know where the problem is concentrated.
Now, this next part is crucial for recognition, I think. The notes describe distinct clinical features depending on the stage of infection. Let's break those down.
Yeah, this is key. The presentation varies significantly from stage to stage, which is why it can sometimes be tricky to diagnose without specifically thinking of syphilis.
So, starting with primary syphilis, what does that look like according to these notes?
The hallmark of primary syphilis is the chancre.
The chancre. Okay.
The notes describe the classic chancre as a painless genital sore. It's typically solitary, so just one, with a clean base and a well-defined reddish margin. It develops rapidly at the site where the bacteria entered.
Painless is the key feature for that classic presentation then.
Yes, that lack of pain is a really high-yield detail from the notes, often distinguishing it from other types of genital sores, like herpes, for example.
Right.
However, the notes are careful to mention that chancres can be atypical, they might be multiple, they might actually be painful sometimes, or purulent, or even destructive.
Okay.
And they can appear anywhere the bacterium entered, not just the genital's extragenital sites too. Lips, fingers, anus.
Got it. A simple way the note suggests keeping the classic primary chancre in mind. P is for primary, and P is for painless. That painless nature is the critical point to take away.
Exactly.
Okay, primary is the painless chancre. What follows that? Secondary syphilis.
That's the next stage, typically appearing around 6 weeks after the primary lesion began. This is where the systemic nature of the infection really becomes apparent.
Okay, so more widespread symptoms.
Yeah, patients might experience systemic symptoms like headache, malaise, feeling generally unwell, fever, and generalized aches. But the most characteristic feature is a generalized skin rash.
A widespread rash. Where does it typically appear? What does it look like?
The notes specify it often affects the palms of the hands and the soles of the feet and the face too, but it can be polymorphic, meaning it can look different on different people or parts of the body. It's not always the same.
Okay.
The notes also list painful lymphadenopathy, swollen, tender lymph nodes, and something called condylomata.
Condylomata. What are those?
The notes describe them as pinkish or grayish raised discs, almost warty looking, usually found in warm, moist areas like the groin or under the arms. They're highly infectious lesions.
Right, highly infectious. Good to know.
Yeah, and the notes also mention other less common manifestations in this stage, like patchy hair loss, eye inflammation, meningitis, or even hepatitis, highlighting just how many systems the infection can affect at this point.
Wow, really systemic.
Absolutely. Most patients, if untreated, will then move into the latent stage after this secondary phase resolves.
Okay, and a memory tip from the notes for secondary syphilis. Think S for secondary, S for systemic symptoms, S for skin rash, especially palm, soles, face,
Yeah.
and those specific fleshy S-shaped lesions, condylomata.
That works. Captures the main points well.
And the latent stage, the notes differentiate early and late latent. What's the difference?
Correct. Latent syphilis basically means someone has a positive blood test for syphilis antibodies, but has no clinical signs or symptoms of the disease. They feel fine.
Okay.
Early latent is defined as infection acquired within the preceding 2 years. Latent is infection acquired more than 2 years previously, or if the timing is unknown.
And why is that distinction important?
Well, the notes specify that latent syphilis is where the risk of the most severe complications starts to increase those of tertiary syphilis. The gummatous, cardiovascular, and late neurological issues really stem from this later latent period if it's not caught.
Which brings us neatly to tertiary syphilis. What are the main presentations listed in the notes for this severe late stage?
Tertiary syphilis represents those serious, potentially life-threatening complications from untreated or perhaps inadequately treated infection much earlier on. It's broadly categorized into neurosyphilis, cardiovascular syphilis, and gummatous syphilis.
Okay, 3 main types. What kind of things would you see in neurosyphilis?
The notes mention several examples. Tabes dorsalis, for instance, affects the spinal cord, leading to problems with balance, coordination, and sensation. Dementia is another potential outcome, a general paralysis of the insane, as it used to be called, and also meningovascular involvement, which affects the blood vessels supplying the brain and spinal cord.
Serious neurological impact then. And cardiovascular syphilis.
This primarily impacts the aorta, the main artery leaving the heart. The notes state it can cause issues with the aortic valve, leading to aortic regurgitation where the valve doesn't close properly. It can also lead to aneurysms, bulges in the aorta wall, or even cause symptoms like angina or chest pain.
Also very serious. And gomata, what are they?
Gomata are described as chronic inflammatory fibrous nodules, sort of rubbery lumps. The notes say they can occur in almost any organ, but are commonly seen affecting the bone and skin, though they can pop up in the liver or elsewhere too.
Okay. And just to quickly summarize the key diagnostic features mentioned across these active stages.
Yeah.
For primary, you're looking for that typically painless ulcer or chancre.
Right.
For secondary, it's the systemic symptoms, widespread rash, condylomata lata, and lymphadenopathy. For tertiary, you're looking for the specific, severe manifestations affecting the nervous system, cardiovascular system, or the formation of gomata. The notes suggest a way to distinguish them. Primary solitary, painless P sore. Secondary, systemic S symptoms and S spreading skin rashes off lesions. Tertiary, terrible T rubble hitting the brain, neuro, heart, cardio, or T issue lumps. Gomatis.
Yeah, those mnemonics capture the essence quite well based on this material.
So with presentations that can range from a simple sore to major neurological issues, what else could syphilis be mistaken for? The notes list differential diagnoses, don't they?
That's a really important point. Syphilis is known as the great imitator for a reason. Its symptoms can overlap with so many other conditions.
Right.
The general list of things to consider, according to the notes, includes other STIs like gonorrhea, chlamydia, herpes, HIV.
The usual suspects.
Exactly. But you also need to think about fungal infections and even non-infectious skin or systemic conditions depending on the presentation.
And there are specific things you'd consider depending on the stage you suspect.
Precisely. For a primary chancre, the notes say you'd need to rule out herpetic ulcers, chancroid, lymphogranuloma venereum, or donovanosis. All cause genital sores but have differences. For a secondary rash, you might think about pityriasis rosea or other viral exanthemas. For tertiary syphilis, well, the differentials are the causes of those specific cardiac or neurological signs you're seeing, because syphilis is presenting as cardiac or neurological issue at that point. The cause could be syphilis or something else entirely.
That really underscores the challenge of diagnosis. And just to reiterate a key point from the notes when differentiating that primary sore, a classic syphilis chancre is typically painless with a clean base.
Right.
Whereas things like herpetic ulcers or chancroid listed here are often described elsewhere as painful and maybe looking a bit different, less clean.
Exactly.
Yeah.
Recognizing those subtle differences or key features like painless is crucial for guiding your investigation towards the correct diagnosis, as highlighted here.
Okay, we've covered what it is, how it presents. How do we actually confirm a diagnosis? What do these notes say about investigations?
The primary way to diagnose syphilis is through blood tests that detect specific antibodies to Treponema pallidum.
Antibody test.
Yes. The notes list examples of these tests, often called dreponemal tests, like EIA, CLIA, TPHA, and TPPA. These tests are used both for initial screening and for confirming exposure.
So a positive treponemal test means you've been exposed at some point. It doesn't necessarily mean active infection.
That's right. They indicate your body's immune system has encountered the bacterium. They often stay positive for life, even after successful treatment.
Okay.
The notes also discuss non-treponemal tests, like the rapid plasma reagin or RPR test, and VDRL is another one. These tests are different. They tend to reflect disease activity.
Activity.
Yes, so their levels, or titers, usually go up with active infection and fall after successful treatment. They're used alongside the treponemal tests to help assess if the infection is current and active and to monitor treatment response.
Okay, so treponemal tests for exposure confirmation, non-treponemal like RPR for activity and monitoring.
That's the distinction highlighted in the material. Yes, it's a two-pronged testing approach usually.
Makes
The notes also mention direct detection methods. You can take samples directly from a lesion, like a chancre or condylomata lata, or maybe a lymph node.
Right.
Tests like dark field microscopy, which looks for the live corkscrew-shaped bacteria, or DFA, direct fluorescent antibody, Or PCR can identify the bacterium itself.
That sounds more definitive, detecting the actual bacteria.
It can be particularly useful in early stages, like primary syphilis, before the body has produced a strong antibody response detectable in the blood.
Okay.
However, there's a really important point the notes make. A positive blood test, especially just a treponemal test, indicates exposure to syphilis, but it doesn't necessarily tell you if it's a currently active infection or a successfully treated past infection.
That's a key caveat.
Absolutely. This is why multiple tests, both types, might be needed, and why in high-risk individuals with an initial negative test, repeat testing after a few weeks or months is often recommended because it can take time for antibodies to develop the so-called window period.
Got it. And the notes offer a memory tip for the tests. T for treponemal test, they tell you if you've touched the bacteria, exposure. N for non-treponemal tests like RPR, they tell you about now, active infection, or response to treatment.
Nice way to remember the core difference.
Okay, we know the diagnosis. How is syphilis managed, particularly in the UK context, outlined in these notes?
According to these notes, management is typically handled in specialized sexual health clinics, or GUM clinics.
Right.
A key part of the approach is comprehensive sexual contact tracing and partner notification. The aim is to identify and treat anyone who might have been exposed to prevent further spread and reinfection.
Crucial public health aspect.
Yep.
And the core treatment itself, what's the go-to?
The notes state the first-line drug therapy is a single intramuscular dose of long-acting benzathine benzyl penicillin. Penicillin remains highly effective.
Just one shot. For early stages.
For early syphilis, yes. Primary, secondary, early latent. A single dose is usually curative. For individuals with a confirmed penicillin allergy, the main alternative drug listed is doxycycline, taken orally for a couple of weeks.
Okay. Are there different treatments for later stages mentioned?
Yes. For latent syphilis, or latent of unknown duration, the notes specify a longer course, typically benzathine penicillin weekly for 3 weeks. Or, again, doxycycline if allergic, but for a longer duration, like 4 weeks.
Right, longer treatment for longer infection.
Exactly. And for neurosyphilis, the treatment outlined is different again. It requires higher doses of penicillin that can penetrate the central nervous system, often procaine penicillin daily injections plus oral probenecid for about 2 weeks, sometimes requiring hospital admission.
Okay, specific approach for neurosyphilis.
Definitely. And the notes also add that treatment protocols can vary depending on the trimester if the patient is pregnant, usually involving penicillin desensitization if allergic, as penicillin is preferred for preventing congenital syphilis.
Got it. What about that reaction some people get after starting treatment? The Jerisch-Herxheimer reaction? Is that mentioned?
Ah, yes, the JH reaction. The notes describe this as an acute temporary febrile reaction, so fever, headache, muscle aches, that can occur shortly after the first dose of treatment, usually within hours.
Sounds alarming.
It can be, but it's important to know it's not an allergic reaction to the penicillin itself. It's thought to be caused by the release of endotoxins from the dying bacteria.
Okay.
It's usually self-limiting, resolves within 12-24 hours. Management mainly involves giving antipyretics like paracetamol or ibuprofen and reassuring the patient that it's a recognized temporary response.
Good to know. And a quick memory tip from the notes for treatment. P is for penicillin, the primary drug, often given as a P shot, IM. Doxycycline is the alternative for D, different patients, allergic.
Simple and effective reminder.
And what about non-medication aspects of management? You mentioned contact tracing.
Yeah, that really centers on the public health side, the contact tracing and partner management. Screening contacts of someone diagnosed is vital, and the notes emphasize treating them preemptively or epidemiologically, even if they don't have symptoms or their tests are initially negative, especially if follow-up isn't certain. This helps break the chain of transmission effectively.
Makes total sense. So what's the typical outlook if treated, and what happens if it's not? And finally, how do we prevent it based on this material?
The notes emphasize that with proper, timely treatment, the prognosis for syphilis is generally very favorable. Early treatment is key, as it effectively clears the infection and prevents the progression to those severe late-stage complications we talked about.
Good news if caught early, and if it goes untreated.
This is where the notes really highlight the potential severity. Untreated syphilis can lead to severe, irreversible complications affecting multiple body systems, particularly the neurological and cardiovascular systems, which, as mentioned, can be debilitating or even life-threatening down the line.
So the message seems clear from these notes. Treat early, outlook is generally good. Untreated, potential for really bad outcomes.
Essentially, yes, that sums up the core message regarding prognosis in this material. Early detection and treatment are paramount.
And prevention. What methods are listed?
The prevention methods listed are pretty standard but crucial. Treating infected individuals and their sexual contacts promptly, even if asymptomatic. Consistent and correct condom use is highlighted as an effective method to significantly reduce transmission risk during sexual activity.
Right.
And routine screening is mentioned as a key preventative measure, specifically noting that all pregnant women in the UK are screened for syphilis as part of standard antenatal care. This is vital to prevent congenital syphilis in newborns.
Okay. Yeah. And finally, we've touched on them throughout the stages, but just to explicitly list the major complications mentioned in the notes that can arise from untreated syphilis.
Sure. The notes list the big 4 categories of complications: neurosyphilis, cardiovascular syphilis, gametosyphilis, those tertiary manifestations, and congenital syphilis when passed from mother to child. It reiterates that the neurological and cardiovascular complications in particular pose serious, potentially life-threatening risks if the infection isn't identified and treated effectively.
Well, we've certainly taken a deep dive into this set of notes today. We've covered everything from the causative bacterium Treponema pallidum, how it spreads, its journey through the distinct stages from that classic painless chancre, to systemic symptoms and rashes, the latent phase, and the really severe potential complications like neurosyphilis and cardiovascular damage if it's left untreated.
Yeah, it's evident from this material that syphilis is a complex disease with a really wide spectrum of presentations, which is why maintaining a high index of suspicion is so important in clinical practice.
Absolutely.
But understanding the stages, knowing what key features to look for, being familiar with the investigation methods outlined here, and knowing the treatment protocols detailed in these notes are absolutely critical steps for achieving good outcomes and preventing those devastating long-term consequences.
Absolutely. And considering the data presented here showing a significant rise in incidence, especially within specific populations, and the severe, potentially life-threatening nature of untreated infection, what this deep dive really highlights, for me, is the ongoing vital importance of public health awareness, ensuring accessible testing, and robust prevention efforts. It's a powerful reminder, isn't it, that even well-known historical diseases demand continuous vigilance in our current healthcare landscape.
An essential takeaway. Couldn't agree more.
Well, thank you for joining us as we unpack these specific notes on syphilis.
Yeah.
We really hope this deep dive has been genuinely helpful for your understanding and maybe for your revision too.
My pleasure. Hope it was useful.
And hey, if you are preparing for the MSRA and found this breakdown of notes useful, you can find more revision material just like this over at pastthemsra.com and freezensra.com.
Yeah, definitely check out those resources if you're prepping for the exam.
That wraps up this deep dive. See you next time.